The curious case of monocular blurring following LPI. Since the advent of laser therapy in the 60s, laser peripheral iridotomy, or LPI, has become the gold standard for the prevention and treatment of the following conditions. In this video, we will present the case of an unusual complication of LPI, discuss its etiology and treatment strategies. The 53-year-old university professor had the procedure done elsewhere 3 months earlier and came for a second opinion regarding seeing a persistent multicolored semi-arc only on the left eye. The symptom was noticed predominantly at night when looking at light sources, although Ree reported seeing it during the day at light reflected on a window pane, for example. He did mention this annoying perception would disappear if he partially closed the eye, as the lid covered the iris defect. Medical history was significant for the use of latanoprost. IOP was within the normal limits on both eyes, and there were no visual field defects nor abnormal optic nerve cupping. On a slit lamp examination, one could notice a patent iridotomy on both eyes, with the one in the right eye being totally covered by the lid, and the one on the left eye totally exposed at the pupillary zone of the iris collarette. There were no signs of cataract, corneal edema, superficial punctate keratopathy, or posterior vitreous detachment. The gonioscopy on both eyes revealed open angles with slight pigmentation of the trabecular meshwork. This unusual complication of LPI has been previously reported by Drs. Murphy and Trope on 13 patients, when they suggested that the possible cause was due to the spherical and chromatic aberration, plus the diffractive interaction of the eyelid and/or lashes with the iridotomy. They recommended performing the LPI at the 12 o'clock position, where it would be completely covered by the eyelid. Their possible etiology was disputed by Drs. Weintraub and Burke, who suspected the phenomenon was caused by the base-up prism effect of the tear meniscus formed at the edge of the upper lid. This hypothesis was confirmed when they made the symptom disappear by bringing the lid forward away from the eye, thus dissipating the meniscus. They also claimed this complication occurred when the iridotomy was fully covered, and did even when it was hidden behind opaque limbal tissue. This is possible because the base-up prism directs the light rays upward through the protected LPI. They recommended studies to investigate the 3 and 9 o'clock positions to avoid the tear meniscus. More recently, Dr. Spath and colleagues published a retrospective study of 172 eyes that had neodymium-YAG laser LPI, which presented with unusual visual disturbances related to size and position. Of these, 40% had varied visual symptoms. Visual disturbances occurred in 8.9% of the eyes with completely covered LPIs, in 26% of the partially covered ones, and in 17.5% of those with fully exposed LPIs. LPIs outside the 11 and 1 o'clock positions were more likely to be fully or partially exposed than those inside these clock hours. The size of the iridotomy was not significantly related to its exposure. One very interesting finding was that the position of the lid was related to the frequency of ghost images, crescents, shadows and lines, but not to halos, glare or blurred vision. LPI performed appropriately is deemed safe and effective. However, there have been reports, as Dr. Spaz study confirmed, of infrequent but annoying visual disturbance following the procedure. In general, iridotomy should be performed under the upper lid, as close to the limbus as possible, in order to prevent a second pupil effect. The 12 o'clock position should be avoided because bubbles formed by laser causing heat and turbulence in aqueous humor preclude adequate visualization and prevent completion of the iridotomy in one sitting. Prescribing tinted lenses, corneal tattooing, pigmented corneal implants, cosmetic contact lenses, topical guanethidine have all been tried before to alleviate symptoms. Some patients do improve or resolve spontaneously, and according to the literature, the explanation for this is uncertain. In this particular patient, only tinted spectacles were prescribed and recommended to be used as needed, since the patient refused to have any other intervention for fear of surgery and of cosmetic blemish. Our approach has been to avoid the nasal position and perform it at the 1 o'clock position as seen here. As both the pupil and the macula are slightly nasal, the chance of stray light reaching the latter is higher if the LPI is performed nasally, especially as in our case, when it was placed in the pupillary zone of the iris collarette. As in any surgical procedure, the indication of LPI for narrow-angle glaucoma must be confirmed by indentation gonioscopy or UBM. We should also take into consideration that the LPI stays covered in all gaze positions and remain that way, because there appears to be less likelihood of developing symptoms when the LPI is fully exposed than when it's partially exposed. It might be unwise to perform it in the 12 o'clock position in patients in whom the lid margin is located directly at the limbus. Long-term studies aiming to determine the adequate position of LPI are necessary to fully elucidate the cause of these symptoms and why some patients, like the case presented, that have the LPI fully exposed have symptoms, while others shown here do not. Thank you very much for your kind attention.